All right, everybody. Thank you so much to Sages, to Dr. Richardson, to Dr. Catania for inviting me to give this talk. I love talking about quality, and this may be a little controversial or maybe full-headed, but I think of surgeons a lot like I think of athletes. And when we're talking about quality, there's a really nice statement that you can't improve what you're not measuring. So you really have to think about what is your goal with quality, what do you want to accomplish, and then measure it to make sure you are accomplishing it, a lot like athletes do. I don't have any disclosures, so technically it's my disclosure slide. So we'll talk about quality in real life. What does this actually mean for your patients when it goes right or when it goes wrong? The scope of the problem, some principles, some basics, looking at guidelines, and then how to do this both pre-op and post-op. So in real life, these are two very real patients that I had. The pictures are not of them, but they're representative. So I had a patient with a big paraesophageal hernia that I repaired, and she was in her 80s, pretty frail, and she had a problem with failure to thrive and recurrent UTIs post-op. This is something that I could have predicted a little better than I did before she had her surgery, and really learned from that experience that we needed to focus on our pre-op education more and to coordinate with families and primary care doctors better. So that was really a learning experience for myself. Ultimately, she did well, but we could have avoided some struggle for her. A second patient who was a very healthy, young perioperative nurse, actually, in our area, and she was taking a GLP-1, both for diabetes as well as for weight loss. And she experienced pretty awful gastroparesis when we restarted that medication within several weeks of her paraesophageal hernia repair, too. And we actually had restarted it at a low dose. She'd been on it for over a year and been doing great, but she developed new onset gastroparesis afterwards. And guess what? That's a mechanism of action of that medication, which was exacerbated by her new RAP and hiatal hernia repair. So definitely that taught me to come up with a plan for med weight loss medications, specifically ones that can cause gastroparesis, and to monitor those patients and really have a plan for them. So she ended up, being admitted to the hospital and needing reversal of medications. And so good experience comes from bad experience. No? All right, so the scope of our problem here is specifically looking at outcomes, because again, quality doesn't really matter in and of itself. It really matters in the context of accomplishing good outcomes and avoiding bad outcomes. So good outcomes that we accomplish are your reflux is treated or resolved. You have a lower medication burden. You can get off of PPIs and H2R antagonists. Receptor antagonists, less surveillance burden. So these folks are not getting serial EGDs necessarily as often as they were before, maybe at all. Certainly improved quality of life. People like to sleep without 1,000 pillows, and they like to be able to eat stuff without feeling awful the next, the rest of the day or the next day. And certainly lower cost. Over time, there's a lot of data that shows if we treat reflux well with surgery, that the actual cost of the patient in many different ways, quality of life years, their performance at work, all kinds of things is actually improved. And certainly lower risk complications. So these are patients who will not progress to cancer or to Barrett's or to other problems. And then also thinking about what kind of bad outcomes we're trying to avoid. Certainly recurrence is a big one. Surgical complications, inadequate management, so picking the wrong surgery for the wrong patient potentially. Frailty, so contributing to making someone who already is on the fence worse with a big surgery, or comorbidity exacerbation, which can happen too. So again, principles of quality. There's actually a really, really excellent Institute of Medicine paper that came out, or actually it's more of a book, called Crossing the Quality Chasm. And specifically what they were talking about is the healthcare system, but I think it actually applies to any program as well. And that's a focus on safety, timeliness, equity, effectiveness, efficiency, and patient-centeredness. And all of the speakers so far have pointed out the importance of these. Even if you're marketing and focusing on timeliness and equity and making sure that you are patient-centered. So really, really important. And again, when we're talking about quality and principles of, you want to plan ahead, you want to prepare, set your expectation, measure, so track your metrics, and then identify and address problems. We are all going to have problems. We are all going to have gaps in quality. But the most important thing about that is to recognize it and do something about it. And I'm really encouraged as a younger surgeon that there's a huge movement to talking openly about failure. And we see some of the greats in this room and throughout this conference talking about their complications and their failures and their disasters and their catastrophes so that they and people like me can do better for all of our patients. And I find that really encouraging. So quality basics. It's not super complicated to find a lot of support as to how you can create quality and measure it in your program. Both SAGES and ASMBS, I would say SAGES is probably the preeminent organization for foregut care. So really glad to be doing this here. But there's really, really excellent guidelines, and there's a guidelines committee of SAGES that has put out a lot of data on this, and if you literally just Google SAGES guidelines GERD or reflux, you will come up on exactly this. This is one of the slides there. It's super straightforward as to how to use it, and there's a lot of data there. So even if you just, if you're looking for good materials, go here. This is a really great place to find it. And then there's also ASMBS position statements and all kinds of consensus guidelines there too. But basically some big considerations that have been addressed earlier is making sure that you know about a patient's esophageal dysmotility. So making sure you're getting that manometry, you're taking a look with GERD, you're taking a look at your pH monitoring. Special considerations also for obesity. There was a mention of a couple of times of bypass being a potentially really good surgery for some of these folks. So if your patient's a BMI of over 35, maybe considering bariatric surgery is an option for them too. Pediatric patients, so these are patients in whom if you do surgery or whatever choice you make, you will be impacting them for the rest of their life. Whether it's surgical or medical, that really is a consideration to be thought about. And then geriatric and frail patients. We are all seeing more older patients. We are all seeing patients who have more comorbidities. So really something to think about as well. And then recurrence. I think everybody in their practice is seeing more patients who have had failed wraps, slipped wraps, all kinds of prior surgeries, and that's a bigger part of what we take care of now too. So this is a really busy slide, but the idea is have a quality plan pre-op for your patients. That does include assessing your whole patient. So if your patient is 89 and doesn't have a lot of social support, that may not be the person to rush to the OR today or next week. That may be somebody to really optimize ahead of time and figure out some support for them. Also enlist your entire team. This isn't actually just your dietitian, your coordinator, your navigator, and your consulting teams, but I actually loved the mention several times of engage your ENTs, engage obviously GI, that's a given, but really starting to think outside the box. In fact, in my practice, I spoke with my dentist, and during a visit with them, we started to talk about reflux quite a lot because they're typically the first line in seeing those patients and the dental erosion that occurs due to reflux. So we actually came up with a presentation and we did a dinner together, and it was a great collaboration that had never occurred to me until we started talking about why I was new in town. So really start to think outside the box as to who is your team. Your team also extends to your patient and their family, by the way. So don't forget that those are really critical supports for quality. And then this has been covered very well by others, but the kind of tools that you can use, don't forget there's really excellent score calculators out there like the Demeester score, and Dr. Demeester's actually here at this conference and gave a talk yesterday. It was really fantastic. And then using things like the frailty index or other quantifiers for your patients should they apply. Considering also things like an ERAS protocol, again, the more that you standardize your care and you use guidelines and implement them in your program, the easier it will be to accomplish quality and to accomplish quality every single time you do surgery. Red flags. So sometimes patients are not good surgical candidates. And as a surgeon, I remember, even in residency, one of the most important things I was taught is you have to be able to say no. You have to know when a patient is not a good surgical candidate. That doesn't necessarily mean they're not a good surgical candidate ever, but it means you may need to use more resources or think intelligently about your whole community of resources before they're optimized to get to the OR. Because the last thing you want to do is do the wrong surgery on the wrong patient or do a surgery and not have the appropriate support for them afterwards. So low social support, frailty, complex surgical history, tobacco, or comorbidities, really important things to consider. And sometimes I work in a smaller community hospital. Maybe that is not the best setting for every reflux patient. So pre-op, these are just examples of what we use in our program, an ERAS protocol that's really based on SAGES and ASMBS guidelines and a lot of literature that's consensus. And we actually had a dedicated patient education visit before every single surgery. So we dedicated that visit to a discussion with the surgeon and with our dietitian for every single patient. So that, and this is in addition to their evaluation after all of the workup was done. This was typically done about a week or two before their surgery, so that we went through a 4-page discussion that lasted about 30 to 45 minutes with each patient to make sure they knew where to go, what medications they were getting, where to get them, what kind of diet they would be on, specifically would they be eating, and what days. I mean, it's kind of sounds ridiculous, but to be honest with you, good experience comes from bad experience. When we started to implement this based on having some patients that didn't do so great, we had fewer calls, so less administrative burden, and we had happier patients that did better. And then also post-op, have a really clear post-op diet. There's some really great resources online. I think UPMC has a really great post-op diet for Nissens and in general reflux patients. Pick one, pick any. They're all pretty good. We had one specifically that was liquids for 3 days and then progressing to softs, and we discussed exactly what that means with our patients. We also tracked outcomes based on Demeester scores, and we had our own little spreadsheet that we tracked everything on outside of NISQIP even. And then when problems happened, we engaged our whole team. That became a discussion immediately with the coordinator, with our dietitian, and anybody else consult-wise that we needed to get them on board. So do not be afraid to face your problems head on and to engage your team to do that. Thank you very much. Really appreciate your attention today.